Dr. B. Vishnu Mahesh Babu, who is currently working as professor and head of the Department of Anesthesiology at Guntur Medical College, Guntur. And he has vast teaching experience of more than 20 years. And also he is actively involved in ISA, ISCCM, ISSP, and IMA. He held different posts in all the field. And he's a recipient of President ISA National Appreciation Award and Best Doctor Awards for 9 times. So he's presenting Pediatric Airway Management, Safety and Adverse Events. Over to you, sir. Yeah.
Thank you for the introduction. At the outset, I would like to thank the organizers for making me a part of this prestigious South Zone Conference of ISA. I'm sandwiched in between the great speaker like Harsur sir, and I'm happy to say that my own postgraduate is talking along with me. That shows the progress of the department in Rangana Medical Kakinada. And in front of our senior most pediatric anesthetists of Kakinada, Dr. Lakshmanan Garu. So it is a common practice for the postgraduates to fumble with the pediatric airway. That's why this topic I am designed for postgraduates particularly. See, my lecture outline will be like introduction, the anatomical variations, what we see in pediatric airway, the physiological variations, airway equipment, the common airway adverse events, and the management, and the take-home message. The airway in infants and children presents unique features that require clear understanding of the anatomy and physiology so that we can prevent so many mishaps in our anesthetic management. The dissimilarity between adult airway anatomy and physiology is more seen in the neonates particularly. That is the reason for more perioperative adverse events. As per the closed claims project reports of ASA, the death because of this pediatric anesthesia, particularly respiratory complications, it was 51% in 1970, that came down to 23 in 1990, and 18% to 2024. That speaks that a lot of equipment is available now, and a lot of monitoring is there so that we can change the technique and decrease the mortality. The difficulties encountered in the management of the pediatric airway could be due to the multitude of factors, which could be a patient factor, surgery factor, or anesthesia-related factor. The patient factor could be related to the age, anatomical and physiological differences when compared to adults and the grown-ups, and the congenital abnormalities are the one important factors which will lead to difficult airway. The surgical factors include the type of surgery, airway surgeries, surgical positioning, and surgeon himself. Anesthesia-related factors may be the relative inexperience of the anesthesiologist who might be handling the occasional pediatric case, not routinely, with equipment which is not fit for the particular age group. So what they say is anesthesiologists who perform fewer than 100 pediatric cases in average per year are more prone to get 5 times complications when compared to these pediatric anesthesiologists who work more than 200 cases per year. So this is the actual, you see a difference between the adult and the pediatric age group here. You've got prominent occiput, narrow nostrils making them obligate nose breathers, large tongue, floppy omega-shaped epiglottis, more cephalad-based larynx and angulated one with a narrow cricoid subglottic region and a soft airway. It differs from the adult airway in the shape and the consistency also. The large occiput neonates and small children results in the flexion of the neck when they are placed supine, increasing the degree of malalignment of the pharyngeal and laryngeal axis. The large tongue and soft tissues of the upper airway, they tend to fall back toward the pharyngeal wall and obstruct during the mask ventilation or the child is sedated. Simple use of oropharyngeal airway and employment of triple airway maneuver, what we do, head tilt, chin lift, and jaw thrust. Like that, if you do that, we can prevent that tongue falling back. So this is the position what the majority of the postgraduates always will not follow this. The main thing is what you see is the line from here is going like this. What is that? The line traversing the external auditory canal it should cross above the shoulders, different from your ram position here. If in case of infant, we have to keep under the shoulders. In case of adults and grown-up children, only you keep here. In a small child, don't keep anything here. That is the most important here. Because this is the correct position where there will be slight extension is preferred. Hyperextension again, it makes the difficult airway. If you keep like that, because large occiput, there will be flexion here. So again, difficult airway will come. So how you measure this correct size of nasopharyngeal airway, and this is the oropharyngeal airway. So the risk will be prepared. Narrow nostrils make nasal obstruction, newborn causes airway obstruction, respiratory distress. When occiput is large and round, when the supine, as I told, occiput flexes head forward, potentially obstructing the airway. Tongue is large relatively. It obstructs the larynx, so the baby becomes unconscious, sedated. Laryngeal and tracheal cartilage soft and easily compressed. Because when you try to manipulate the airway, excessive flexion or extension of the head can obstruct the airway. The larynx is higher in cephalad, C2, C3 level. The tongue and soft tissue can obstruct the airway. The cricoid ring is narrower than the glottic opening. The funnel-shaped larynx, risk of obstruction from subglottic edema. The narrow laryngeal and tracheal diameter, even small minimal edema can produce obstruction. The neck is short here. It's difficult to have the landmarks here. When you want to do any percutaneous technique there, it's difficult for you. The innards and tonsils fill the posterior pharynx, very particularly when you got large tonsils, what you call kissing tonsils are there. They can cause obstructive sleep apnea and difficult ventilation. The baby tooth become loose, accidental aspiration of tooth may occur. We'll be very careful about that. What are the physiological changes important here? How does immature nervous system will predispose to airway complications? A child's increased parasympathetic tone, immature brain, underdeveloped respiratory center, and behavioral responses, they increase the risk of airway complications and respiratory failure. The increased parasympathetic tone is the important factor because that hypoxia causes bradycardia. Whatever insult occurs in the pediatric age group, it manifests as bradycardia. This bradycardia causes hypotension, that bradycardia further worsens the hypoxia. The children are easily sedated because of immature neurons, less myelination, weak blood-brain barrier, little prior exposure to drugs. All these things lead to increased risk of respiratory depression. The child is uncooperative. They can't allow instructions. They struggle more and resist, and stress leads to increased metabolic rate. Again, this stressed child will cry. Because of crying, they get increased secretions, increased airway irritability, increased risk of laryngospasm, increased risk of bronchospasm, and increased airway edema. Apnea prematurity, the more the child premature, the greater the risk. They have altered ventilator response to hypoxia, hypercarbia, and sleep. They can be made worse if the infant is stressed, cold, or ill. Apnea worsens hypoxia, that worsens bradycardia, that leads further worsen the hypoxia. The chest wall is more compliant and the ribs are more horizontally placed when compared to adults. The FRC is lower in children as compared to adults. When infant takes breath against the resistance, the chest wall actually moves inward as the belly moves outward. The inward movement of the chest wall decreases the amount of air that enters in. The FRC, as you know, is about 70 ml per kg in adults, whereas about 80 ml per kg in children. Whereas the oxygen consumption in infant is higher when compared to adults, it is 6 versus 3. The dead space is more here when compared to adult. The lower FRC coupled with increased oxygen consumption leads to rapid desaturation during apnea, very particularly when you do manipulation of laryngoscope intubation, in spite of giving good pre-oxygenation. The type 2 fibers are there in diaphragm, and hence they are prone to early fatigue and to early desaturation. As you know, the airway resistance is governed by the Poiseuille's law, where the resistance to flow is inversely related to the fourth power of the radius of the airway. Even a small amount of narrowing due to edema or inflammation of the pediatric airway could have been a catastrophic events. Conditions that can result in narrowing will be like tracheomalacia, laryngomalacia, laryngeal clefts, iatrogenic cause such as vocal cord palsies, subglottic stenosis, compression of the airway by a mass located outside, or a simple manipulation can produce that. So management of these conditions always have a common denominator, avoiding airway trauma and subsequent edema to tissues constituting the airway. What is the thing you need? Ensure good ventilation and avoid hypoxia, to pre-oxygenate the all children, to minimize apneic periods, to obtain a good mask fit, to avoid barotraumas, ventilate with appropriate size breathing circuits and circuit bags. As you know, people prefer to use Miller blades initially, where the epiglottis is elongated in infants, and a straight Miller blade is generally preferred to directly lift up the epiglottis. This provides better visualization of the laryngeal inlet and insertion of endotracheal tube under vision. Curved laryngoscope blades are used by hooking the tip of the blade, keeping the valvula and indirectly lifting the epiglottis. It is experience you can do. I can intubate a premature child with a 2.0 Macintosh blade. It is mere personal only. So now the main thing is, can you use cuffed or uncuffed? The old standard teaching of avoiding cuffed tubes until the age of 80 years is now not followed by majority of the people. An increasing number of anesthesiologists now prefer cuffed endotracheal tubes over the uncuffed ones. A cuffed endotracheal tube has the advantage of high first pass success rate, less air leak and gastric insufflation, minimal escape of anesthetic gases responsible for the operation theater pollution, and reduced incidence of post-extubation stridor. The coupler should not exceed 20 centimeters of water to avoid the tracheal mucosal damage and inhibit tracheal perfusion, and monitoring of the coupler is mandatory. To this, luckily we have got now micro cuffs. Micro cuff tubes are especially designed for children, providing effective sealing at low cuff pressures. The cylindrical shaped polyurethane cuff is placed more distally to avoid endobronchial intubation and damage narrow cricoid region and vulnerable mucosal tissues. So the old calculation is not followed now. For calculating endotracheal size above the 1-year child now, for uncuffed tube, follow the Coley's formula, where age by 4 plus 4. Cuffed tubes you can follow either Motoyama or Doracher formula, where age by 4 plus 3.5, or Kine formula, age by 4 plus 3. So the calculus depth of insertion is in the oral for neonate, weight in kg plus 6. Nasal we don't use routinely, weight in kg plus 7. In the child it is age in years by 2 plus 12, age in years by 2 plus 14 for nasal route. So these are the actual recommendations given by American Heart Association, where still they use only cuffed tubes from 8 years only. The different sizes they give like that. Now supraglottic airways are coming in a big way. The choice of these supraglottic airways often based on the weight. The newer designs allow for use in premature and small for raised neonates also. The second generation supraglottic airways, like the common things what you use this iGel, is a port for the gastric tube are now routinely used for short surgical procedures as an alternative to the endotracheal intubation. They are useful rescue airway devices for maintaining the oxygenation and anesthesia in a failed intubation situation under GA. So SES in comparison to ETT have a lower incidence of perioperative respiratory adverse events in terms of laryngospasm and bronchospasm. So these are various sizes you follow, the LMBS with different cuff pressures. You must be knowing about the Broslow-Luton system. It correctly measures a child and a Broslow-Luton color coding tape is applied. The child is allowed to lie flat. You measure from the head of the head, top of the head, to the ankle, not to the toes. The child is allowed to sleep like this, lie like this, and gives a correct measure of the child's age, child's requirement of this endotracheal tube, oral airway, everything, the dose of drugs, everything like that. And mnemonic is given like give pediatric registrations priority, you will be overwhelmingly grateful. So this is the Broslow-Luton system, which gives different sizes like that. So assessment is basically when a child has abnormal cry, hoarseness of voice, snoring or sleeping in semi-prone position, any known congenital acquired disorder, upper ear respiratory infections, everything, it indicates that you may anticipate difficult airway. With the measurements like lower lip to chin distance, tragus to corner of mouth, pterygium distance, neck circumference, ratio of the height to TMD, all this can predict a difficult airway. There are some syndromes like hypoplastic mandible macrognathia, mid-phase hypoplasia, macroglacia, all syndromes make difficult airway. There is a copper index where you see the chin opening the previous episodes of difficult airway, uvula and range. Based on the copper index, we can predict the difficult airway in syndromic babies. The common pitfalls are, just 1 minute. Delay and recognition or upper airway obstruction should be continuously monitoring the child. You have to identify the laryngospasm, bronchospasm. Immediately you have to intervene and save the child. And this laryngospasm is because when the child is in a lighter plane, you have to deepen it. When the child has got inadequate head position, reposition it and reopening it. Large adenoids, oropharyngeal and nasopharyngeal airway. Difficult face mask, 2-hand, 2-person technique. Blood foreign body secretion, suction and removal. Alveolar collapse, alveolar recruitment maneuvers. Gastric hyperinflation, decompression to be done. Inadequate depth of anesthesia, deep anesthesia with your volatile anesthetic like your sevoflurane. Laryngospasm, give propofol or muscle relaxation. Opioid-induced muscle rigidity, give muscle relaxation. Bronchospasm, very low dose of epinephrine and bronchodilator like sevoflurane can be given. To summarize this, the immature pediatric nerve system creates a lot of risk for you. The pediatric anatomy of the larynx predisposed to airway obstruction. Neonates and young children become hypoxic easily because of the premature respiratory system and their inefficient mechanics of breathing. Caring for a baby or infant without cart-sized equipment jeopardizes the patient's safety. To recognize the bronchospasm, laryngospasm in earlier place and to be prepared to manage it. The most important thing is we have to consider the limitations of our knowledge as a pediatric anesthesiologist and assisting staff with us and the equipment available with us to know whether we can deal the pediatric airway correctly or not and cope up with the knowledge about the latest equipment so that whenever a problem comes to you, you have to be in a position to deal. If you got a problem, if you suddenly try to do a new technique, you will not save the child. So get acquainted with all equipment, a normal child where normal airway is there, then only you can succeed. Thank you for the attention. This is actually photograph from online only. We got one child who is getting recurrent papillomas, getting surgery every year in Kakinada. So the child every time comes for extraction, child keeps a face mask on her own. She says, this is not a small, give me bigger one. Like that, we have seen child for 10 years continuously. Every year she comes and she gives us to give that white drug, don't give that drug like that only. So this is things. So now the child may cooperate to you, but some problem is the attendants may not cooperate to us. Thank you for the patient listening.